Now, before I begin with my presentation, I'd like to draw your attention on the screen and show you some very important information about Edentulism to set the tone for my presentation for tonight. First one is the Edentulous state represents a loss of integrity of masticatory system, which is frequently accompanied by adverse functional and aesthetic sequelae. According to the World Health Organization criteria, the completely edentulous patient meets the WHO criteria for being physically impaired, disabled, and handicapped. And as of today, completely edentulous patient population in the United States alone would increase from 33.6 million to 37.9 million by 2020. Now, simply put, edentulism is a serious problem, and we have to recognize that this exists. And for us who are here today, we are part of this dental community that should recognize that this problem has to be addressed. And for tonight, I'm going to present to you some of the treatment modalities that's going to address this existing problem. So good evening, everyone. My name is Dr. Rainier Darve. And for tonight, we're going to discuss a very interesting topic, which is called implant-supported prosthesis for edentulous arch. And what I'm going to do today is I'm going to talk about 4 treatment modality options that are relatively contemporary and are really a good and viable option to addressing this problem. So the first one that I'm going to talk about is the 2-implant overdenture. And I would want to assert that this treatment modality should be a standard of care or the minimum standard of care for pretty much all dental practices around. Then I'm going to talk about the fixed hybrid prosthesis and conversion, also known as the all-on-4. And I'm interested to present this one because this concept or this term all-on-4 has been very popular in the community. And it would be nice to elaborate a little bit more. And in fact, I'll give some more details about this, so people will have a better understanding on what they hear around about all-on-4. Then third, I'm going to talk about this new thing as well, which is conus or syncone, which is a removable implant-borne prosthesis. It's a variation of an all-on-4. It has some similarities and differences, and I'd like to show a completed case of this conus abutment as well. And then lastly, which I'm really excited about, I'd like to talk about the all-digital driven surgical and prosthetic treatment, which is also known as the N-sequence. We recently finished a case. That's the case that I won't be presenting today, but I want to share the experience I had with completing this case. And for tonight, I will be talking about all these treatment options, but as a prosthodontist, you know, I can go very detailed on every step of the procedures, and I'm referring to mostly the laboratory procedures, which I'm sure some of you are not going to be interested to hear about that, and will just cause more confusion or might as well can overwhelm you. So what I decided to do is to help you out understand this presentation by having your mind set on conventional denture. I want you to draw upon your experience or your knowledge in conventional denture fabrication, because you'll be surprised a lot of the treatment modalities that I'm going to talk today is based on the principles and key elements of conventional denture fabrication. So to understand my presentation tonight, I'd like you to draw upon these key principles in the conventional denture fabrication. And what I'm going to do as well is we'll use conventional denture as we discuss each treatment modality and compare and see for yourself as a matter of reference if one procedure is relatively doable by you or not. Now, to facilitate better understanding, I think I decided to give you some more tools, okay? And then these are lenses. I'll give you 3 lenses from which I want you to view these treatment modalities. The first lens is the denture support. Use this lens to see how each of these treatment modality offers the support for the prosthetic. And what I mean by that is it's like building a house. If you don't have a good denture support, house will just crumble. And in every treatment modality that I'm going to present, I want you to focus on looking at what kind of support is being provided in the fabrication of denture. So use this lens once in a while as I go around, as I go for each topic or each treatment modality so you have a better understanding if it's going to work or not. Now, the second lens I want you to use is the dentist experience lens. With this one, I want you to put yourself as if you're the clinician performing this procedure. Figure out, based on your own experience and knowledge about the procedure, if this is something that you can do for your practice or you can do eventually. Try to assess if the technique is too difficult or too complex or it's manageable. And again, from time to time, I'm going to add up my perspective too and help you understand the treatment modality from this perspective. And lastly, for better understanding, the third lens that you're going to use as we move along is the patient expectation lens. Use this lens to view each of these treatment modalities from the perspective of the patient. Okay? Try to see why one patient would benefit from one treatment modality over the other. Because eventually, you are the doctor, you are going to present this option, and you are going to think of what's best for the patient. So using all these lenses, I'll make sure that you understand, or will make it simple to understand these complex procedures that I'm going to present. Other than that, if it's really still too complex to understand what I'm going to present, think of all these options that I'm going to present as something as treatment modality options available for edentulous patients. So we are going to solve edentulism on our own little way, each patient, every patient at a time. So ready to begin? So first, we're going to talk about the 2-implant overdenture, which I would say the standard of care for edentulous mandibular arch. And this is how it's going to look like. You have a denture that is the same as conventional denture that you fabricate. But the uniqueness about this one is you have 2 implants with corresponding attachment that is found on top of the implant and also beneath the denture. 2-implant overdenture is indicated for patients that are fully edentulous, mostly used for patients with extensive bone loss or soft tissue loss. You don't have enough ridge height and you have some issue with retention and stability. It's best used for patients having difficulty in dexterity to clean the denture, especially if the other option would be something that's fixed. A 2-implant overdenture is something that the patient can remove by themselves. And its practicality. The cost of fabricating a 2-implant overdenture is significantly a lot lesser than all other options that I'll be talking about. So it's relatively affordable, and again, very practical solution for a patient needing a solution for edentulism. Now, usually as a restorative doctor, you start off with this case. You will be presented with a patient with 2 implants coming from surgery. You have those healing caps. And about by this time, your denture should have been fabricated. So you can start fabricating your denture prior to this, and surgery will be done. And when it's ready, patient will present to you with this one. So I'd like to start with this step. And then what you're going to do is get your prefabricated denture. It's the same conventional denture that you fabricate normally for an edentulous patient. The only unique about this conventional denture is on the intaglio surface, you have this hollow space. And as you notice, this hollow space is pretty much designed to accommodate those attachments. And then from that point, you can order a locator abutment and also the retention kit. And in the retention kit, you will have different parts. And I'll talk to you each one of them as we go along. Now, first thing you do is get the locator, remove the healing cap, attach this locator abutment over that implant. Now, the next step, if you're planning to do this process, is to place this white ring, otherwise known as the locator block outspacer, which is actually intended to work like a rubber dam to prevent any material from going into the sulcus in the next succeeding steps. So once you have these white rings, the next thing you have to do is put the denture cap male assembly or the metal housing. Okay? So far, that's the step. And then the next thing that you're going to do to complete this process is try out your denture, the hollowed out denture. But at this point, you have to go back and assess how much height, because there's some space management skill that you have to deal with this one. When you try the denture here on the mouth, you want to make sure that that metal housing is not in contact with the acrylic part. So you have to hollow that further. Now, in order to facilitate easy adjustment of the space without overdoing it, you can use a fit checker, okay, mix, and apply it on the intaglio surface of the hollowed portion, seat the denture, and after it sets, you will find something like this. And if the acrylic base is in contact with the metal housing, you will see some exposure of this acrylic. And in order for you to remember this or to facilitate easy trimming, you can use the Thompson stick, make a mark on that exposed area, remove the fit checker, and then you can further cut the space to allow enough space for that metal housing. Now again, the key here is you don't want to overdo it. You just want it just enough space to accommodate that metal housing. Now, to move along, the next step here is you're now ready to pick up that metal housing and have that metal housing attached to the intaglio surface of your denture. So you can use any other type of acrylic, a self-curing acrylic. And in this case, I use the ERA pickup. So you dispense that onto those hollowed surface and then seat it there on top of those attachments. And the only thing or the most important thing that you have to assure at this point is that it is in the right position. If you have a bigger space, this can move around. So to prevent that wrong positioning of your denture as the material sets, you can have your patient bite on the right centric occlusion while the material is setting. Now give some time for the material to cure, and after that, you're ready to take it out. Now the next few steps are some of the things that you need to know in order to make sure you have the right attachments for your two implant over denture. When you take it out, you will see this. Remove those white rings. Get your acrylic burr. Remove the excess ERA pickup material or acrylic that you have used. Make sure it's clean and good. There's no any rough or pointed areas that can cause injury on your patient. Then grab the locator core tool. This is pretty much the only special tool that you need to have for this particular treatment modality. This locator core tool has a 3-piece multifunctional instrument. So you have the male removal tool, which I'm going to show you how to use that. You have the male sheathing tool, and then you have the abutment driver. You can use this abutment driver to actually put the abutment on the mouth of the patient over the implant, but they are more preferred clinical instrument to use. This is mostly for laboratory use. But in any case, the way you use this locator core tool is this way. You remove the black processing replacement male with this core tool. So you just push it in, grab it. It has this sharp side of the locator core tool. Take it out, and you should be able to take this out easily. If you don't have this instrument, you can probably use an Explorer to take out this black processing plastic nylon, because you won't be using this anyways. So you can discard this. Now, once you remove those black pieces, now you're ready to put in the retentive mechanism. This is the retention replacement nail. And if you notice, on the corner, you have 3 different colors. You have the blue, the pink, and the white. And it has its corresponding pounds, 1.5, 3 pounds, and 5 pounds. What it tells us is the amount of retention. In this case, I use the blue. So if I use the blue for both attachments, that is equal to 3 pounds of force to apply in order to remove the denture from the attachment. So at this point, you are going to select. Consider patient's dexterity, consider the need of how much retention patient wanted. You can start off with blue, and then later on, during follow-up checkup, you can change it. But in any case, you still use the same locator tool in inserting this retention nylon. So you pretty much just align it and push it. And then there you have it. And then as quick as probably about 30 minutes in the entire steps, you will end up with a prosthesis that has its own retention using the 2 implant over denture. So it's really a nice, sleek, and relatively easy implant-supported prosthesis that you can offer to your patient. Now, as I've said, use this lens. Why is this better compared to conventional denture? If you look at a conventional denture, it's just resting on top of the edentulous area. Unlike a 2 implant over denture, it's on the tissue, but it has an implant and retention mechanism to attach those prostheses. So basically, you will classify conventional denture as thesis supported, okay? And the 2 implant over denture is tissue supported but implant retained. So again, going back to the support, you will have a better chance of a working prosthesis with two implant over denture compared to the conventional denture. Now, let's see a dentist experience. Now, if you are doing this, there are things that you need to know. Look at the cross-section. This is how it's going to look like. You have the teeth, the acrylic base, you have the attachment, the locator, and the implant. It's all about space management. That's the only probably complication or difficulty in this process compared to fabricating a conventional denture. Manage the space. You don't want any thin areas for your acrylic base. It can make your denture fragile or, perforated eventually after some use. Or you don't want even to have a bulky lingual area where it's going to affect the tongue movement or annoys the patient as far as having a bulk and not the same anatomical experience that they have. They will have these two bulky areas in the lingual. So just focus on that, making sure that when you are fabricating the denture, the initial denture for this, just think about that space. You can bulk it up or you can anticipate the space that you will be needing in order to avoid any acrylic-based perforation or bulkiness. Now, another thing is it's just a matter of selecting the right cuff height for your abutment. So in the market, it comes available in many different heights. And basically, all you have to do is get your periodontal probe. After you remove the healing cap, measure from the most superior or the tallest area of your tissue, measure up to the base or the platform of your implant, and use that as a cuff height. What you want to achieve is a relatively correct cuff height where you only have 1.5 millimeter of retention that's sticking out of the tissue. This is really the best way to manage the height. If you chose the wrong height and you end up really tall, then you're going to have perforation in your denture. If it's too low, then the patient tissue will be encroached when you place that metal housing attachment. So this should be relatively easy to do. Just get your periodontal probe, measure, call the rep, order the locator attachment, and you can proceed with all the steps. Okay? And then other than that, just learn how to use the torque wrench. There is some amount of torque needed to attach those locators. In this case, it's 35 nanocentimeters. And just learn and be familiar on how to use the locator. The torque wrench. Basically, that's all you need for this type of prosthesis. Patient's expectation, as I've said, this is a wonderful, easy treatment. Patient would love it. It solves the problem of conventional denture directly related to retention and stability of the denture. The reason why, especially mandibular arch, the reason why conventional denture fails or why patients are not satisfied with that, it's directly related to retention and stability. You can achieve good aesthetics with it. You can achieve good form. But the problem with function is attributed directly to the stability and retention of the denture. And having these two implants as a retentive mechanism will really solve this major problem. Patient would report improved oral function. Although sore spot can still be an issue, remember, it's still a tissue-supported prosthesis. It's very simple, predictable, and very cost-effective, and provides the benefits of aesthetics, phonetics, bone preservation because of the implants, increased comfort, and better psychosocial state and enhanced nutrition. Patient won't worry anymore that denture can just fly out of their mouth, especially when they are in a social gathering. So it's really a good treatment modality, a more practical one for the most patients. That's why I really encourage everyone to know this procedure and offer this one in their own practices. Okay? Are we good with that? All right. So now we'll talk about the second part, which is the fixed prosthesis utilizing the all-on-4 treatment concept. There will be some details on this presentation and this part, and I'd like to start now. So all-on-4 looks like this. 4 implants, basically described as the 2 posterior implants in an angle and a prosthesis that is screwed or attached over those 4 implants. But the concept itself is described as this. And I'd like to show you a video while I'm explaining it. Okay. So it's an implant-supported fixed restoration with 4 implants that supports the prosthesis. You have tilted posterior implants. That is the classic all-on-4. This is designed to maximize the use of available bone, and the tilt can be as much as 45 degrees. And the whole concept is designed or follows the idea of immediate function. As soon as you place the implants, you are ready to load the implants and fabricate a fixed interim prosthesis. It's a highly functional prosthesis from provisional phase to final phase. It's a predictable treatment option for patients that are edentulous or with terminal dentition. And this is very efficient approach, especially if you're working as a team. I really encourage that when you go into this type of treatment, you have to work, if you're the restorative doctor, you have to work with somebody who's really good at placing implants, because that's the department that you don't have to deal with so much, because the complexity alone or the skill and the time needed to restore it is equally difficult as well. So just split the problem between 2 doctors or a team. And this all-on-4 is founded on biomechanical principles. Now, as far as who are candidates for this again are for patients who are completely edentulous. And a lot of times, these are the people who have been wearing denture and has not been very happy with their conventional denture. They want something more. And more means not fabricating another set of conventional denture. There has to be a big or dramatic upgrade, and that is by utilizing 4 implants. Sometimes just utilizing a 2 implant over denture may not be satisfactory for some of these patients who's been frustrated for many, many years. And if that's the case, all-on-4 or having more implant is a better option. It is also indicated for patients with teeth, but otherwise terminal dentition. They're all badly decayed, needed to extract. No teeth can be left behind or can be left for a fabrication of a partial denture. Or this can be also for situations where there's a periodontal disease. Mobility provides poor prognosis to keep the teeth in place, and they have to be extracted. So these are some indications for an all-on-4. And for some reason, some patients there, they don't want to have or are unwilling to go with additional grafting procedures or surgical procedures. All-on-4 can be a good option for some of these cases because, especially when seeing this radiograph, you can avoid anatomical structures like the sinus by choosing the angled implant. If you make a straight implant, you have to have enough bone height. Otherwise, it can perforate to the sinus, and then therefore you need grafting for those. So it's indicated for patients who otherwise don't want to have grafting procedures. Okay? Now, I'd like to explain all in four, because there's so many details and steps to do this, but let's do it in phases. Generally, when you're thinking of all in four, think of it this way. The first phase is the pre-surgical treatment. There are steps involved, and I will explain that. Then you go the surgical phase. Okay? Implants are placed. And then the denture conversion, meaning the conventional denture is transformed. That's why it's called conversion. Transformed to something that's fixed on the day of the surgery or immediately after. And then once implants have all integrated and healed, few months after, then you go to the definitive prosthesis. So these phases will take over time. And every phase has a lot of steps in it. So let's start with pre-surgical phase. You see the patient for the first time, patient excited about all in four, they want to go with this one. You will find out about that in the patient interview, clinical exam, if they're qualified or indicated for this particular treatment. Radiograph, CBCT happens in this pre-surgical phase. And then at this point, you can fabricate the interim prosthesis. And again, this is just like a regular conventional denture for now. Or I should say, it can be like an immediate denture. And then from fabrication of this interim prosthesis, you can, for most of the time, you can just duplicate this interim prosthesis, and this can serve as a surgical guide as well. Now, once you have completed this pre-surgical phase, you coordinate with your surgical doctor as far as placement of implants. Then you go on the surgical phase. This is the time of surgery. This is the time where straight implants and angled implants are placed. Alveoplasty is done, or has to be done if needed. Bone grafting has to be, if indicated, has to be done as well. Once they're completed with placing the implants, suturing, and placement of the healing caps. Then, on the classic approach of all in four, on that day of surgery, the denture is converted. You have the prefabricated denture made, and then you will undergo a process of fixing, altering this denture so you can attach this removable denture to the newly placed implants so the patient will walk out the operatory with their prosthesis on. So that's the denture conversion part. And then 4 to 6 months thereafter, complete healing and osseointegration have occurred, then you will proceed with the definitive prosthesis phase where you fabricate the final prosthesis, and this is best described as involving fabrication of the bar, which involves designing and milling the bar and incorporating that to your final prosthesis. Because the final prosthesis is the one that the patient will wear for the longest time. The interim prosthesis is just a temporary one while we're waiting for the final one. Okay? So let me dive into, again, in the more specific step. Let's talk about the denture conversion. How does this happen? Or how do you go about this? After the surgery, there's a suture, there's the healing cap. And then you have your denture that was fabricated during the pre-surgical phase. So in the time of surgery, this is ready. Okay. Now, if you're the restorative doctor, this is what you're going to do. You identify the location of the abutments. So grab your denture, you index the position of the abutment by placing some sort of material like exabyte, Regisil, or what have you on the intaglio surface. Insert the denture over the newly surgerized or newly placed implants with healing cap. And with this material, you will be able to copy or get the indentation of where those implants are located. Now, you need to identify this because you are going to make a hole. You don't want to put it in a wrong hole, otherwise you will have a lot of holes. So you want to make sure that it's in the right place, and you can do it this way. So hollow out the space of the denture, and although this seems to be a very simple procedure, actually it can be complex because your hole can grow bigger and bigger, because even though you just follow where the index is, the reality is it doesn't always go there. So next one is you remove that white healing cover, the white cap, and you attach this temporary metal cylinders. Okay, this is a component of restorative where you will attach the temporary or interim prosthesis on this temporary copings. Okay, and once you tighten this, just hand tighten this over the implant, you insert the hollowed out denture over that. You will have those temporary copings protruding out of the hole. You need to attempt to check the bite. If those temporary copings are interfering with the patient's occlusion, you have to cut that, you have to adjust that. These are the steps that I want to explain now, because later on, the other treatment modality, this will all be eliminated in that process. So, but in this classic traditional all-on-4 step, you have to have those copings cut while you're checking the patient's occlusion. Now, if it doesn't want to go into the hole, you have to make the hole bigger. That's just how it is. The next step is you are going to pick up those impression or those temporary coping. So you have the hole here, and around that hole, around that impression, around that temporary coping, you will place acrylic around that. Let it set so it will grab onto that. So when all the four posts or four temporary copings are captured by that acrylic, then in order to remove this prosthesis, you have to unscrew it. All right? So put acrylic around the hole, around those temporary copings, let it set, and then take it out. Now again, it's not as straightforward as it may sound, because depending on material you use, like if you use a regular self-curing acrylic, there can be some exothermic reaction where heat is generated and patient can feel some burn. So you don't want the patient to experience that. So once the material sets, get your driver, unscrew, and you are going to remove the whole thing, just what you see on the photo on the right. And then what's next is, in spite of being in the maxillary arch, Patient don't want to have the palatal area. So you are going to cut the prosthesis, make it a U shape, and you will end up with the prosthesis just like what you see on your right of the screen. This is then inserted on the patient on the day of the surgery and screwed down on the implants, and the patient walks out the clinic after the surgery with the prosthesis. That's the beauty about this type of treatment. Now, 4 to 6 months after, you will make the final denture. And these are the steps. Remove the interim prosthesis. You will see no more suture. You will see no more blood. You will see a well-healed tissue. And you assume, after the evaluation from your periodontist or surgical doctor, that implants are well integrated. Then you're ready to do the final steps. So with this, the next step is you take the final impression. So how do you go about this? There is an impression post really designed for All-on-4. You place this over those implants or those abutments. You screw them, make sure that they are hand tightened, and then in order to increase the accuracy of your impression, it's best to splint all these 4 independent posts. So get a wire, connect each bar or each post with a wire utilizing the GC resin pattern. You will appreciate this more when you start working on this case and your bars are not fitting down the road. So this is a valuable step to make sure that there will be no movement of the post. Okay? So take the impression with this. It's an open tray impression. Then you are going to pour your final impression. You attach the analog, place the tissue moulage or the soft tissue to fabricate the soft tissue model, and then pour up your impression. So you will have your master cast. Trim it nicely, because this is what you're going to use to fabricate the final prosthesis. Unfortunately, you are not certain, you should not assume that your master cast is accurate. In spite of the fact that you did your due diligence of splinting those impression posts, following the instructions of correct impression, you cannot assume that your master cast is accurate. You have to verify and you have to make sure this is accurate by doing another step. That's just how it is. Otherwise, you will be wasting your time and money. So how do you do that? How do you assure the accuracy of your master cast? You make a verification jig. So how do you fabricate this? And I promise this will make sense. So in your master cast, you put another impression post, just like what you see in the photo on the far left. If you want to do this on your own, you can also send this to the lab. But the way it works is I use floss and then salt and pepper technique. I use the GC pattern resin to connect all this posts together. So you will have a red or a GC pattern that connects all the posts. So obviously, I made it on my master cast. If I take this out, unscrew it, and then I put it back in, it should fit because I made it from my master cast, right? Now, the way this works is you will see your patient back, and you are going to use this verification jig to test if your mounting or if your master cast is correct. You want to make sure that this verification jig fits the mouth of the patient. Okay? If it doesn't fit, who is wrong, the master cast or the patient? So if it doesn't fit, your master cast is wrong. So obviously, you have to retake the impression or make necessary adjustment to adjust the position of those analogs in your master cast. So verification jig is a step to make sure that you have an accurate model and you are ready to proceed with the next step. Okay? Then, from this point onward, it's like fabricating a conventional denture. As I was telling you, we need the key principles in denture fabrication because most of these treatment modalities are based from conventional denture. So get your jaw relation, get your wax rims, get the right jaw, centric relation, make those marks, set the teeth, make a denture wax-in, denture wax try-in. During that try-in, verify the centric, check for aesthetics. If you can attempt to do checking of phonetics, do that as well. And once you're happy with this try-in, you can now say that the teeth position are correct because the patient loved it. It is in the right vertical dimension. It looks better when they smile. So therefore, you can assume that the denture teeth are in the right position. You really need that information in order to proceed with the next step. And the next step is to fabricate the substructure bar. This bar are designed and milled. They are designed using the constraints of those denture teeth positioning. Okay? So you want to make sure the teeth position are right so that based from that position, the bar will be fabricated, designed, and milled according to the space and positioning of those teeth. So we fabricate the bar, and then we reset the teeth over the bar. Remember the wax try-in you did earlier? You're going to take this out and put it back or put it over those bars. This is just my fancy way of putting it back. I index the position of the teeth, mounted in an articulator, and I can assess the space that I needed to reposition these teeth back. Otherwise, don't make it too complicated. Work with your dental lab, and they can do this for you. Once you get it back, it looks like this. It's a wax try-in with the bar inside, and you need to try this in on your patient. If I can give my 2 cents here now, the challenge here is when you're trying this in the mouth, it takes time. You have to unscrew, you have to screw, unscrew, evaluate, and in that process, your wax is melting. So you really have to do this really, really fast. You really have to have a way of, you have to have really a good experience in evaluating if the centric relation, jaw relation is good. Otherwise, you will run out of time and your teeth are gone. So techniques I do, I have the patient chew some ice chips or soak the wax try-in on ice chips before I actually put it in. So those are some of the techniques to prolong the denture wax try-in without having the wax melt on me. And after the try-in, everything's good, verified, fit is perfect, then you process the denture and then it's ready for delivery. So that is the steps involved, the steps involved in the all-on-4 final prosthesis. Okay? Now, denture support. Grab that lens. Look at the support. Compare the 2 implant over denture where you classify this as tissue-supported and implant retained. And compare this to entirely implant-supported and retained. There's no more tissue contact. Patient will never ever have any complaints about sore spot. Every time the patient chew or bite, there's no more impingement on the tissue. So just by looking at the denture support, you know that all-on-4 will have a high probability of patient satisfaction compared to a conventional denture or even compared to a two-implant overdenture. So you have to understand the biomechanism or the idea that is entirely implant-supported and retained. Dentist experience, it's great. You benefit from the angled positioning of the implants on the posterior. If you're the surgical doctor, you don't have to do any grafting. You can avoid that by making an angulation. You can reduce the procedure by not grafting. For the restorative doctor, you have a better AP spread. Essentially, AP spread is we want to put extra teeth on the back, but we cannot just extend it way back because the denture might break. But with an all-on-4, when you angle the implant, you are extending the bar further back and you can put more teeth for occlusion. So that's essentially what AP spread advantage that you can get from all-on-4. And the benefit of immediate loading. You as the practitioner, if you place the denture on the day of surgery, you will have fewer adjustments and you don't have to reline or condition the denture every time the patient is coming back for adjustment, for a checkup. Because the denture is fixed, it's not removable, it's not changing, and you don't need to reline the removable prosthesis. However, you have to look at the workflow. It requires several appointments. To do this in its entirety, you are lucky or good if you can finish the case anywhere from 8 to 15 appointments. I even heard 25 appointments. It's complex, especially if you're just starting out with it at the beginning, but I'm just telling you that's the reality. It takes a lot of appointments to do this. You will spend a lot of many clinical and laboratory hours. You cannot see a patient in 1 hour. You have to spend 3 hours every time, 2 to 3 hours, for at least for those major parts, like converting the denture, or in your case, if you're not familiar with impressioning on implant prosthesis, you have to spend a little bit more time, probably an hour and a half or 2, compared to, let's say, doing a regular crown and bridge impression because of all the components needed to be attached on the implants and those splinting of the post before you can even make the final impression. So a lot of clinical and laboratory hours. It requires coordination between your surgical doctor and you. Okay? I think that's a good thing. Implant is a restoratively driven treatment. Surgeons, periodontists should know where the implant should go. So coordination is always good to have a more predictable prosthetic outcome instead of being surprised that implants were placed in any angulation and direction. The reality is, with all-on-4, there are unexpected procedures prior to final prosthesis. Even though they're wearing the interim, even though they're happy about it, after you need to wait, let's say 3 or 4 months, but in between that, patient can experience tissue coming off, denture breaking. You have to see the patient, take it out, put it together, adjust it, and then 2 weeks after, it will happen again. This time, it's a different area. The patient is also figuring out correctly how they're going to bite, and you don't really have the best opportunity to make a great denture on the interim stage. Because otherwise, if you can, at the time of surgery, make really a great denture, why do you have to make a final denture, right? So the reality is, you cannot really make a good interim prosthesis, oh, I'm sorry, a prosthesis at the time of surgery. That's why you have that interim phase. The plan versus implementation often have a mismatch. You would wanted to place the implants on this particular position. As a restorative doctor, that's where you plan it. But the surgical doctor may change that position during the time of surgery for some unforeseen events, like there's not enough density of the bone, we have to alter the position or what have you. Sometimes too, you need to have, let's say, enough bone reduction, because again, just like two implant overdenture, all-on-4 really requires space. For the maxillary arch alone, you need about at least 12 to 15 millimeter of space for the entire accommodation of the teeth, denture base, bar, and the tissue contact. Now, you need sometimes bone reduction at a certain amount so you can achieve that number, but a lot of times there's a possibility that bone reduction is not followed as planned. So there are those things that happens along the way. And very classic, it's very normal to see position of implants and angulation different from where you have planned it originally. Okay? But as far as patient expectation, since this is a highly functional restoration, patients feel very comfortable and functional during the implant healing period. They wear something that's fixed. They can function right away. Especially if they compare that to the conventional denture. They have this in their mouth and they're pretty much happy with that. They feel like it's their own teeth. Patient reported that a lot of times. There's really a positive psychological impact on the part of the patient and not worry of the loss of teeth. A lot of patients are afraid, especially with terminal dentition, that at the time of surgery, teeth will be removed and then they'll walk out without any teeth. They're really afraid of that scenario. So when you tell them that there is an all-on-4 procedure where you can have teeth, hopefully on the same day, it gives them a good satisfaction or comfort knowing the fact that they will have teeth. And the protocol has been out there for many, many years, and you have 5-10-year data that supports a success rates of this type of treatment modality. Are we good with that? Are we still good? Okay. So conus and syncone, it's another type of implant-supported prosthesis, and I'll be brief on this one. It looks like this. You have sort of a conventional denture. You have those abutments, those posts, and you have attachment that's attached on the denture. But this time, they are not nylon. They are solid metal-to-metal contact. So you start off with patient who you put 4 implants. You fabricate conventional denture as it is. Take a final impression, custom tray, final impression, make the denture all the way to processing from this model. And same denture. Again, the only difference is you have this 4 or the location of implants hollowed out. And if you look into closer, you can see a metal framework underneath. You need that metal framework to support your acrylic-based denture because this type of prosthesis is solid in the mouth It's not tissue contact or just passively touching the tissue, but is entirely supported by implant. Because this is too solid, when the patient bites, your denture can break. You need to support your denture by having a framework underneath your denture base or within your denture base. Okay? So you send the impression. So in this case, you remove the healing cap, put the impression post, take the impression, you will have a model. You don't need a verification jig. If you want to do it, that's fine. Send it to the digital center. They will scan your master cast. And what is unique in this process is they fabricate this post in a very extremely parallel angulation or parallel position with about 5-degree taper around the surface. But they should all be parallel, and you will understand why as we go along here. So they scan the model, digitally design it, and they, in the fabrication process, because it's digital, they can make it really precisely parallel, unfortunately, on the computer. You are still eventually going to use the model, and again, you're not really sure if the model is accurate or not. But as far as design in the computer, they can, or they will make this as parallel as they can. So you have this. Again, the intent is to make those parallel. And then you get the retentive part, which is called the syncone, that goes over that post. So on the day of delivery, you have your denture made with a framework underneath and hollowed out. But again, you have to manage the space. You don't know how much hollowing out you need to do further. You have your abutment. Make sure you know how they are oriented as you transfer or place them in the mouth, because you want to keep that parallelism across the arch and those syncone attachment ready. Place them over the mouth, torque, place the syncone, and at this point, it's like the 2 implant over denture, where you're going to use the denture, figure out the amount of space, make sure it's not holding up, do the same process of adjusting the space, and then put the ERA pickup material or acrylic. In this case, I put some venting holes on the lingual surface so the material can vent out, and put it over the syncone, have the patient bite, and wait until those materials set. And then the whole idea here is you should be able to take this out from the mouth, and that is the type of prosthesis this looks like. So the lingual surface would look like this, the intaglio surface. Instead of those nylon attachment, you have the syncone, which is metal, which attaches to the conus abutment, which is metal. And the idea here is the retention is cold weld. So patient wears it, it stays there. As the patient wears this more, it will sink in more, it will be very retentive. So that's the whole idea. The patient is very happy with this one. It's like a fixed restoration, but is removable. Okay? So if you look at the denture support, you have implant supported and retained for all and four, and it's the same as the conus and syncone. The only drawback here is that, the advantage of this one is that it's removable. When it comes to maintenance, when it comes to dexterity of the patient, or I would say cleansibility, you're better off having a prosthesis that is taken out so they can clean it well, than follow the regimens or protocol of cleaning and maintaining a fixed prosthesis, just like an all-on-4. But as far as denture support, they are very similar as far as functioning. You will have a great prosthesis if it's entirely implant-borne and retained. Okay? Then it's experience. Put yourself, if you're going to do this, and I'll share you what you might expect. My biggest concern here is the path of draw. Okay? As I've shown you earlier, I'm going to put acrylic or ERA pickup here and put it over the shin cone. Once it's set, I have to cross my finger and pray that those abutments are really parallel. If not, I won't be able to take it out. Right? And I'm prepared to do whatever it takes to take it out in case if I cannot take it out. But you have to remember your prosthesis has a metal framework. How are you even going to cut that inside the mouth? So I hesitated to proceed with this step. What I did, and you can do this as well, is I tried it out on my model. Although again, model and patient might be different, but I want to try it first on the model. So I make my jig like this. This serves as my prosthesis, sort of. Although it's acrylic, it can bend or what have you. But I want to try it in and see if I can take it out. And when I was able to take it out, I have little fear at that time, and I'm not totally confident just yet, but I know that there is some degree of, or some chances that it will work out well. And it did work out well. So that's the only thing about this conus, to make sure that they're parallel, and it will be, it will work out well. Patient expectation, they feel the benefit of a fixed restoration, even though this is a removable prosthesis. Cleansibility is a big plus for them. Unfortunately, they have challenge in removing this. It's so retentive that my patients are having difficulty taking this out. But they were creative. They actually helped me, especially my first few cases in doing this. They shared to me the techniques. They said they drink hot liquid like coffee for a while, and it will make it easier for them to take it out. One of my patients bought an infant spoon, you know, like the rubber type. That's what they use to pry off and remove it. So they tend to be creative, but they really like this type of prosthesis because it's a fixed prosthesis and it functions like one. Okay? Function is never a question, and easy maintenance. And what I mean by that is when tooth breaks, patient will come into your clinic. It's in their best experience to repair the denture by just taking out the denture, go to your lab, fix the teeth, then repairing the broken tooth inside the mouth of patient on a fixed prosthesis. Or remove the entire assembly, unscrew everything, and then repair it outside the mouth. Either way, patient is not pleasant with that experience if it's something that's fixed. But for something like conus and syncone abutment, where you can remove the prosthesis, it's easy maintenance for them as well. Okay, so I'll be fast here. Lastly is end sequence. I'm really excited to present this one because I would say this is the direction of how we should treat a Edentulous case. The price tag here is still very expensive, but hopefully it will go down as we do more of this. It is fully digital guided surgery, and in fact here you're really designing the treatment in such a way that you can be sure that the patient will get the denture on the day of the surgery. All on 4, that's the intent. but there are times you cannot do it, especially if the patient is really tired or there's no immediate stability of the implants. But for the end sequence, it's really designed, as I will show you, for the patient to get the denture on the same day, because everything is planned digitally prior to the treatment. So anyway, it looks like this. This is actually a screen capture of a real case on the computer, meaning this design will actually be milled and transformed into a real prosthetic. So end sequence utilizes digital designing and planning in order to facilitate this type of treatment. So what's an end sequence? It is a treatment protocol that utilizes advanced technology in digital dentistry for the fabrication of immediate load, full arch restorative prosthesis. It is a guided surgery and restoration. So meaning it guides the surgical doctor on where to place the implants, but it also guides the restorative doctor in the prosthetic part of the treatment. So it covers both. It's so streamlined that the patient will significantly have fewer appointments. I was telling you All-in-4, this is very similar to this, requires what? 8 to 15 if you're doing it good, but for the end sequence, dramatic reduction in appointments. You can probably do this at the most 4. You can easily get this 3 appointments. It's digitally designed and manufactured, and it's all based on CBCT, where you do all the planning and collaboration. So instead of us taking impression and having a model, and you're doubting the accuracy of that because of the inherent changes in materials and in techniques, you are now using a CBCT, which is very accurate. So therefore, you can actually plan and fabricate the prosthesis as accurate as it can be. That's the nice thing about this end sequence. So what do you get from end sequence if you use this protocol? So after the planning, you can get a bone reduction guide. Surgical doctor likes this because they are not going to guess how much bone to be removed. They will simply utilize what end sequence have provided for them, which is a bone reduction guide. It's attached on, let's say in this case, in the maxilla, pinned and secured well. You will have that white area. It's like the bone protruding out. The surgical doctor will just remove that. Don't even have to worry if I reach the 15 millimeter reduction or what have you. They will just have to follow the flat surface of the guide to be certain that enough bone reduction is done. So end sequence provides you with a bone reduction guide. They will provide you with a surgical guide. This surgical guide is placed on top of that bone reduction guide after that step is done. And you have this surgical guide where it will guide the surgical doctor on exactly where to place the implants at an exact location and angulation. Pretty much you don't have to think anymore. You just have to follow, because all the thinking happens during the planning. You will have surgical and prosthetic components included. And as I was telling you when we're discussing All-in-4, you have these temporary cylinders that you need to cut to avoid occlusion. They will be all pre-cut for you because, again, it was planned on the computer. So you just have to put them all together. And if you see next to that cylinder, you have this silicone part. That is the size and dimension of amount of tissue that will be left. It was extrapolated from the data and predicted how much tissue height will be left after the bone reduction and suturing. So that's what you have there. Then you will be getting from them a finished temporary denture. It's already U-shaped. You don't have to convert anything. It's already made. And then you have this clear duplicate prosthesis, which will eventually be used, and I will explain this later on, as your try-in denture. All this will be made for you, including all the documentations needed. And in the documentation, it's a thick documentation explaining what parts and components that are needed to fabricate the prosthesis. And at the same time, we'll show you the step-by-step procedure as well. Okay? Now, the workflow, if we compare this to the all-in-4, you have pre-surgical, surgical, denture conversion, and definitive prosthesis. This, in a traditional all-in-4, this will take you about 6 months for one arch. But in this case, the pre-surgical treatment phase, you don't have to see the patient make the denture, duplicate the denture for surgical guide. You just have to sit down and plan it in the computer from the CBCT. And then the surgical, denture conversion, and definitive prosthesis, they will all be combined all together to make the protocol using the end sequence. So it was significantly abbreviated. So it uses this software, so accurate and extensive. And then from this software, you will be able to plan the position and angulation of the implants. You have all the information in front of you. You have your CBCT. You can decide the length, the width, the diameter of implants. You can plan the denture as well. You can superimpose the opposing arch. You can figure out how wide the teeth are. You can, I know for most students here, when you're doing a wax try-in and the teeth is short, you want to move it down, you have to melt the wax, right? And then bring it down, put the wax again and try it in. But in this case, you just use your mouse, grab on the teeth and bring it down. As simple as that. So that's the prosthetic part. And then all the parts needed to make this work is also available and ready to ship to your practice. Again, the bone reduction, we discussed this. You can plan this on the software and see how much bone reduction. Again, in this planning, it involves you, the restorative doctor, the surgical doctor, and a biomedical engineer. The three of you in an online go-to meeting, and you sit down and discuss this. You can see brilliant minds talking to each other because, you know, you need an experienced surgical doctor who understands where to position the implant, and an experienced surgical or restorative doctor where they can say that the wax try-in is good from a computer alone without really seeing the patient. So it takes some sort of experience to really be good at this. So just quickly, clinical case. This is a bone reduction procedure. Surgical guide placed, secured, bone reduced up to the level of the guide. Surgical implant guide is placed. Now implant will be sequentially placed in the right order and the right angulation. Once that's done, you put the impression post, the temporary cylinder. It's numbered, so you know exactly where it should go. Then the ready-made converted denture is just placed over there, and then all you have to do is just squirt it. You squirt it with your acrylic. It will go around. You don't even have to worry about leakage of this material that would cause burning sensation in the patient. because everything is protected with the silicone protection that you see there. It secures it in place. It's airtight. So when you squirt this material, it just fills it up and go out in an exit hole and not going into the surgical site. And then you're done with your provisional. It looks like that. Okay. Now, there's this clear duplicate prosthesis, which is unique on this end sequence, because we still need to wait 3 months or so or 4 months for osseointegration. But at that time, you just use this clear duplicate of the same prosthesis you delivered at the time of surgery, put it on the patient, and that is your final impression. That is your verification jig and bite recording and your setup for try-in. So you put that on a patient. If the patient said, I want it longer or shorter, then you adjust that clear acrylic. If the bite is off, you adjust that clear acrylic. Okay? And then once you make that adjustment, you're going to send this clear duplicate to the company, and they will put that in their data, adjust their computer, their data, extrapolate from the new changes they got from the clear duplicate prosthesis, and they will fabricate the prosthesis for you, send it to you, see the patient, and then you just have to screw it. Simple as that. That's how the final prosthesis would look like with a metal bar, and that's how the patient would look like on the day of delivery. Okay? So denture support is the same as All-on-4, but this is computer guided. Gone are the days where you are doubting the accuracy of the models that you're working with. Everything is so precise with this. As far as dentist experience and expectation, you can assure that they can get it on the day of the surgery, at least for the most part. Okay, because there's a planning that happens before that. Significantly reduce the number of patients' appointments. Okay. Significant reduction in laboratory and clinical hours. It facilitates effective coordination and teamwork. Predictable outcome. Patient is very satisfied with the function, and patient is really satisfied with the overall experience of going through the process, because it's many of these appointments abbreviated into a very short treatment times. Okay, so just a recap, you have 2 implant over denture, which I encourage you to really do routinely in your practice. Discourage patient from conventional denture. Even though they have a good ridge height, especially in the mandibular arch, conventional denture for mandibular arch just doesn't work. They always have inherent issues of retention stability. Again, for maxillary arch, it should work, but for the lower mandibular arch, encourage them to do 2 implant over denture. Simple, easy to do, and very affordable. The All-on-4, again, you've been hearing about this one. There are so many steps involved here. It is a great implant-supported prosthesis, a little bit complex to go about, but it's very satisfactory for the patient. They really love this one. Conus is a good one. It is relatively cost-effective compared to All-on-4. Feels like a fixed prosthesis that they can remove, but depending on the technique you do, you might be in the same boat that I was, where you might have some issues on the parallelism. And lastly, the end sequence is the direction of where Edentulous treatment should go, because it's so precise and it's so effective that patient can have very less treatment times with the doctor. Again, same principles have to be followed. Accuracy of record is paramount. CR is very important. The choice of prosthesis should match the patient's needs. They should be able to afford it. They should be able to be happy with the choice that they're going to do, and that's with your help. And on your part, there should be a continuous development of clinical skills on every case. And as always, follow-up care, maintenance are essential parts of the successful treatment outcome in any type of this treatment modality. Okay, that's all what I have to offer for tonight, and thank you very much for your time.